I'd like to thank Paul Mason for organizing this spectacular conference and for inviting me to talk about cholesterol, diet, lowering cholesterol with statins. But first, let's cover my disclosure. What is it that motivates me to want to study this area of science? Well, in general, my disclosure would be for my primary area of research. I'm a neuroscientist with a PhD in biology with a specialty in neuroscience. I've been funded by all major federal organizations as well as some drug companies. But I'm not going to be presenting neuroscience work today. What I'm going to be presenting is something actually that is very personal and is unfunded. And it's based on my own risk for developing heart disease. A bit over 20 years ago, I was diagnosed with a genetic disorder. It's called familial hypertriglyceridemia. I had astronomically high triglycerides, about 10 times higher than would be typical, and I had extremely low HDL, and I also was overweight. Plug in my numbers, and you can see on this graph, I had about a 15 times greater risk of developing heart disease compared to someone with optimal lipid measures. And I took this very seriously, and I was very concerned. I went to see my doctor every year about this. And at some point, after numerous years, really about 8 years, in which I persisted in having extremely high triglycerides, despite diet and exercise, my doctor urged me to go on medication, including statins. Now, I knew a whole lot about the brain, but very little about heart disease and not much about statins at all. So what I decided was to put my PhD in biology to good use. I started reading about triglycerides and heart disease. And over the years, I would say what happened was I had a combination. At best, I was disenchanted. Really, at worst, I was outraged at what I learned about heart disease in conflict of interest. And that's what I'm going to share with you today. Essentially, the way I look at it is it's very nice to see how this relates to a story of the man who lost his keys. And what did he do? Well, he's looking for it under the streetlight. He doesn't know where his keys are. And someone walks by and says, well, you don't know where your keys are. Why are you looking under the streetlight? And he says, well, that's where the light is brightest. And to me, that tells you a bit, as it epitomizes the search for the cause for heart disease, and cholesterol has been under the streetlight. And why is it that cholesterol has been under the streetlight? Well, frankly, what I'm going to talk about is this conflict of interest. The conflict of interest really originates with the vast fortune, the incredible profits that have been derived from demonizing cholesterol. So you want to sell a product, whether it's oatmeal or corn oil, Cheerios, and of course medications such as statins. The primary way to do this is to say that it lowers cholesterol. And so part of the real problem is that there's a financial conflict of interest motivating companies to be able to say that they can lower LDL cholesterol specifically. So what I'm going to talk about is that there are far more important factors than LDL that are associated and even mechanistically connected to heart disease. So I'll be talking about low-carb diet, emphasizing triglycerides and HDL, in particular one component of the LDL called the small dense LDL. I'm going to talk about a disease, familial hypercholesterolemia. These people have extremely high cholesterol, and I'm going to say that this is misunderstood, that a subset of these people do have more heart disease, but it's not because of their high cholesterol. I'm going to talk about whether or not someone on a high fat diet, a low-carb diet, should be taking a statin if they have high cholesterol and specifically high LDL. And finally, I'll talk a bit about coronary artery calcium. This is one of the most important biomarkers to tell you about your risk for developing heart disease. And this really has been ignored to a great extent. Clearly, it has not been emphasized sufficiently. So let's go back into the 1980s, when Brown and Goldstein won the Nobel Prize for their study on the LDL receptor in people with familial hypercholesterolemia. Brown and Goldstein basically declared LDL guilty of causing heart disease. And here is just one of their papers in which they reviewed this, stating as a fact it's a causal relation of LDL to heart disease. The problem, of course, at the time was there was very little strong evidence that LDL actually caused heart disease. And so there was a study that came along that was very important, that helped to convict LDL of causing heart disease. And that study here is the Mr. Fit study, in which a large number of men, hundreds of thousands of men, were followed, middle age, for quite a few years. And they looked at their rate of death from heart disease in terms of their cholesterol levels. So you have here a rather frightening graph, which came out of their work. And you look at relative to the people with the lowest, and this is total cholesterol, and 1.0 is their rate in which they died of coronary heart disease. And so when you go from 1 to 2, that's twice the rate of death of heart disease. 3 is 3 times, and 4 is 4 times the rate of death from heart disease. And so as you see, with every small increment of cholesterol, you're increasing your risk of dying of coronary heart disease. So at the highest level, you see that you're over 4 times likely to die of coronary heart disease with high cholesterol compared to low cholesterol. So this helped to demonize cholesterol in general as far as causing heart disease. So I read this paper, and what I want to show you is the actual data from the study. This is a derived aspect of the data. I want to show you closer to what was actually found in the study. And that I'll show you in blue bars. So the same data in the blue bars derive the data in the red bars. So I'm going to show you the percent of people that did not die of coronary heart disease based on their cholesterol levels. And that is in this graph. So you're seeing in the blue bars the percent of people that did not die in relation to their cholesterol levels. And you can see it's virtually 100% all across the board. These people were horribly uncooperative. Almost none of them died of coronary heart disease. So I'm going to add a line in at 99%. So you can see that at the lowest level of cholesterol, just slightly more than 99% did not die of coronary heart disease. And at the highest level of cholesterol, which is considered really dangerous, slightly less than 99% did not die of coronary heart disease. So how do you get from the blue data to the red data? The blue data basically says across the entire range of cholesterol, there's only about a 1% difference in the rate of death. But the red data are very alarming, showing very high incidence of coronary heart disease with higher levels of cholesterol. So this is what they did. When you look at the lowest level, that's your reference level, 0.3% of those people with the lowest cholesterol died of coronary heart disease, CHD. And let's go to the highest level of cholesterol. And at this point, what you got is about 98.7% of the people did not die of coronary heart disease. So 1.3% did die. The difference across the entire physiological range is about 1%, which is rather trivial, almost no difference overall in death. So again, let's go from the blue to the red. The way they did this was, and you look at how do you get over 4.0, 4 times the rate of death from coronary heart disease, you take the 1.3 and you divide it by 0.3 and you end up with 4.3%. Okay, 4.3. And this is how he appears as if there's a 400% increase in death from heart disease. You take a 1% difference and amplify it to 400%. And why did they do this? Well, frankly, there wasn't really good evidence that cholesterol caused heart disease. So it's a bit like at the time, the banks were too big to fail. People say that. Well, cholesterol was too big to fail. So they couldn't just say there's almost no difference, lowest to highest cholesterol. What they had to do is amplify the effect to make it appear as if cholesterol was essentially toxic, atherogenic. So let's look at the people with the highest cholesterol. These are people who would be urged to go on a statin now, in which their cholesterol is extremely high. And yet, here are middle-aged men. For many years now, you're looking at their cholesterol extremely high. About 99% of them did not die of coronary heart disease. Let's look further into this. Familial hypercholesterolemia as a result of genetic modification. These people, because the LDL doesn't bind very well to the receptor, have extremely high cholesterol levels. And in the first half of the 20th century, what was found was a subset of people who died young had extremely high cholesterol diagnosed with hypercholesterolemia. And you see that the cholesterol is in their artery walls. Very simple idea. High cholesterol in the blood seeps into the artery walls. It therefore clogs their arteries and is going to cause them to die at a very young age. And this is now the contemporary view. Here is a contemporary study in which emphasizing without proper treatment for people with familial hypercholesterolemia, you can see that they're going to die at a relatively young age. So they're unlikely to make it past 50. You can see that they're likely to have cardiovascular disease or an early death by the time they're in their 50s. And so this is the current contemporary view of familial hypercholesterolemia. The high cholesterol interferes then with cardiovascular function. So as a scientist, I've got a very simple hypothesis. High cholesterol clogs arteries, causes people to die young. So the first thing we should see from the literature is that people with FH, which is familial hypercholesterolemia, should die young. The second thing is, it's pretty obvious, pharmacological reduction of LDL should be able to reduce the rate of mortality. So let's look at those studies. Well, the first is there are quite a few studies looking at lifespan of people with FH, consistently showing that these people have a normal lifespan. And here is a contemporary study, which I think is very important, in which you're looking at genetically confirmed FH, people with high LDL cholesterol, and you're looking at their rate of death over different decades, from birth on up into their 80s. And so the line at 1.0 is showing you the average rate of death, in this case in the Norwegian population, at each age range. And so the first thing is when you look at the first few decades of life, there's an extremely low rate of death. So everything is relative. So very few people, only 1 or 2% of people die in the first couple decades of life. And so that slight increase in the bars in the first few decades is not statistically significant, showing it's almost no death in the people diagnosed with FH, and it is not statistically significant. What's really important is as you look as people get older, there's actually a decline in the rate of death. And after 60 years of age, it is lower than the average for the Norwegian population. And in fact, it's statistically significant. People with FH, extremely high cholesterol, in their 70s have about a 40% reduction in death compared to the general population. This is some disease. This is a disease that actually enables you to be healthier. And the reason for that is that cholesterol is a part of our immune system. The people in their 70s have a normal rate of cardiovascular disease compared to the population and a lower rate of cancer and diseases having to do with inflammation. So it is in fact healthier to have extremely high cholesterol for people over 60 years of age. And it's not just for people with FH. It goes for the general population. I had the pleasure to work with an outstanding group of clinician scientists, and we published a review of all the literature looking at mortality for people over the age of 60 as a general population. And what you find in general is that the people over 60 with the highest LDL live longer than the people with low LDL. And there's no study showing shorter lifespan of people over 60 with the highest LDL compared to the lowest. So we concluded that elderly people with the high LDL live as long or longer than those with low LDL. And you certainly want to question then whether LDL is actually clogging arteries. These are people living a long life, long healthy life with high LDL. And you certainly want to wonder, why would an elderly person want to lower their LDL when they can actually be living longer than someone with low LDL? Now, let's look a little further into people with FH, because there's sort of a template to guide us as to whether or not high LDL is to be disconcerting to us. So here's a study in which you have people who all had a heart attack, people with FH, all put on a statin. And so now you can see their LDL levels here on the left. And so you've got a subset of these people, all on a statin, have coronary heart disease. They have a second heart attack after the first. And a subset don't have a second heart attack. And you look at their LDL levels, and there's no difference. So LDL doesn't tell you about the population that's now having the second heart attack. What's the difference between the population? Well, the people who have the heart attacks, more than 3 times as many, are smokers. And of course, this is a risk factor for everybody, but it may very well be that this is even more important for people with FH. And this has nothing to do with their cholesterol. And so this is a very important risk factor for heart disease for anyone. It may very well be even more important for people with FH. But what's very clear is it's unrelated to their LDL levels. And they look over 25 years. These individuals, they studied people. And you look over a 25-year span. The people who were smokers, only about 40% of them were able to go this period of time without having a coronary event. But the non-smokers, over 80% of them didn't have a coronary event. So what's really important here is to understand the people with FH have the same risk factors for heart disease as everyone else, and it's independent of their high LDL. Now let's look again at an FH study. This is so incredibly important because again, we've got two groups of people with high cholesterol, and they're all on lipid-lowering medications such as statins. And you've got one group with no heart disease and another group with heart disease. And again, no difference in their LDL levels. So LDL does not tell you which group has heart disease. What is the difference? Here it is such an important measure. The group here in blue, okay, is the group that develops the heart disease. And they have extremely high coronary artery calcium. That calcium belongs in your bones, not in your arteries. It is a great indicator of the future risk of developing heart disease. So with equivalent level of LDL, what you find is the people who have high coronary artery calcium are the ones that have the heart disease. And this goes for the general population as well. Those who don't have the heart disease have zero coronary artery calcium. And again, this is independent of their LDL levels. So what is another difference between the two groups? This is so important. When you look at the people that have the coronary events, that have high coronary artery calcium, what you find is significantly higher fasting blood sugar, fasting glucose, in the group that had the events. So they are in the pre-diabetic, borderline diabetic range with high fasting glucose, whereas those that didn't have events have nice low blood sugar below 100. So this is what's really important. We need to know what factors are actually associated with heart disease. And it's not LDL. In this case, it's high coronary artery calcium. It's high blood sugar. One more study that I think is so incredibly important in comparing people with FH with heart disease versus those that don't have heart disease. So when you look at this graph of this study, contemporary study, looking at people with extremely high cholesterol, total cholesterol, and LDL, and you can see the recommended LDL levels below 100, total cholesterol below 200. These are two groups of people, one diagnosed with coronary heart disease and one without. And you see minor differences in their HDL and triglycerides, but huge LDL levels, which are statistically equivalent. So what is different about these two groups? There is a genetic difference. The group that has more heart disease has a polymorphism, a different form of a gene for a protein called prothrombin. Prothrombin is a clotting factor for both FH people as well as the general population. The general population that has this genetic anomaly has significantly more heart disease, and it is independent of LDL. So this is what's so important. The people with high FH, as well as anyone with a high cholesterol, what you're going to find is the clotting factor, prothrombin, is critical factor in determining whether or not someone develops heart disease or not. And that is independent of the LDL levels. So there's a vast literature on this topic, and we've actually covered this. We published a review in which we covered coagulation factors versus cholesterol in people with familial hypercholesterolemia. And the conclusion we came to was that, in fact, it's hypercoagulopathy. It's high levels, prothrombin, or fibrinogen, other clotting factors, and the inability to break up clots, called fibrinolysis, that you find is the critical factor related to heart disease rather than cholesterol. And so if you look at fibrinogen, which is really a powerful clotting factor, what you find is fibrinogen is independent of age and is associated not only with coronary heart disease, it is also associated with stroke. And cholesterol absolutely does not relate to heart disease as well as stroke as good as fibrinogen. So this is a critical factor that contributes then to heart disease independent of LDL cholesterol. So here I just summarized a vast literature. When you look at the risk factors, primary risk factors for coronary heart disease, they all mechanistically link up to what's in the center. That's a picture of red blood cells in the formation of a clot. So clot formation as well as degradation, all these risk factors contribute to the increased risk for developing heart disease. And it's independent of cholesterol, and I've highlighted toward the bottom that the subset of people with familial hypercholesterolemia, this is the subset of people that have increased clotting factors. So therefore, it's all people with FH have high cholesterol. But the subset of people with FH that have high fibrinogen or high prothrombin, they're the people much more likely then to develop heart disease. So is LDL completely innocent of causing heart disease? Well, yes and no. There is an aspect of LDL, which is covered so very nicely by Paul Mason in his lectures. But there is a component of LDL which can be considered damaged LDL, called small dense LDL, that is associated with heart disease. So if we look at a person that is healthy with low blood sugar and low triglycerides and high HDL, what you're seeing is coming out of the liver and in the blood you'll find native LDL. This is called large buoyant LDL. And this is an LDL that's essential for providing nutrients through the blood. And it's a form of LDL that is not associated at all with heart disease. But if a person has a high blood sugar and high triglycerides, what you find is as the LDL proceeds through the bloodstream, it then sort of deteriorates. It becomes a small dense LDL. Small dense LDL is found, a high proportion of small dense LDL is found in people typically who have higher blood sugar, who have higher triglycerides, who have metabolic syndrome, higher blood pressure, high blood sugar, high triglycerides. So it is associated with heart disease because it exists, in a sense, in a damaged metabolism. So here's a study that actually looked at that to confirm what I'm telling you about. And so you look at the people that have the highest small dense LDL. And what other measures are there associated with it? Well, the people that have the highest small dense LDL have extremely high triglycerides. So that's on the left side of this graph. So they have extremely high triglycerides. The people who have a low level of small dense LDL have an extremely low, healthy level of triglycerides. You look on the right, the people diagnosed with metabolic syndrome, have an extremely high percentage of small dense LDL. The people who are not diagnosed with metabolic syndrome are the ones who have a low level of small dense LDL. So it's really important to see that when you see an association of small dense LDL with heart disease, all it means is that that small dense LDL is found in a damaged metabolism, in an unhealthy person who has multiple risk factors. The small dense LDL does not exist in a vacuum on its own, does not cause heart disease. So here's another very nice observational study. When you look at the people who have the highest small dense LDL, here followed over quite a few years, what you find is those with the highest small dense LDL, and again, which is found in conjunction with high triglycerides and high blood sugar, you find those are the people that have the highest rate of heart attacks, coronary events. The people with lower level of small dense LDL have much fewer heart attacks. And so again, small dense LDL is found in a damaged metabolism, in an unhealthy metabolism. Let's look at the large buoyant LDL. This is basically the kind of LDL that's produced by someone on a low carb diet with low blood sugar, low triglycerides, someone who is exercising. You're more likely then to have potentially a higher level of LDL, but it'll be primarily a large buoyant LDL. And you see here on the right, there is no association of large buoyant LDL with coronary events. So this is a far more sophisticated approach than just talking about LDL-C. But this is really important to see that the type of LDL is associated with the health of your metabolism. Healthier metabolism produces a dominance of the large buoyant LDL, which is not associated with heart disease. We summarized much of this research in a review we published last year. I have worked with cardiologists and diet experts, so I was really very fortunate. And so I want to emphasize in that, here's a figure from our paper showing that on the low-carb diet, you see where the arrow is pointing on the left, dramatic increase, greater levels of large buoyant LDL in the people on the low-carb diet, which of course is at worst benign, potentially very helpful, and a small increase in LDL-C. But let's look on the right side, whereas down is a good move for all these biomarkers, and you see the small dense LDL declines compared to a low-fat diet. So the low-carb diet is moving all the biomarkers in the right direction, including the small dense and the large buoyant LDL. So we've taken care of the first one. It's very clear that having high LDL not only doesn't cause you to have an early death, having a high LDL enables you to live longer. But now let's look at what happens with pharmacological reduction of LDL. Does it actually reduce the rate of cardiovascular mortality? Well, there are a couple of primary approaches pharmacologically that I have time to cover. The first is called the CETP inhibitor. This is a completely different mechanism from statin. So these drugs interfere with an enzyme that helps to convert HDL into LDL. So the result is you have an increase in HDL and a reduction in LDL. It's the ideal change because high HDL is associated with less heart disease. So this was to be a blockbuster drug. And the contrast is with statins, which interfere with HMG-CoA reductase, ultimately resulting in lower LDL. Two completely different mechanisms. So let's cover first the CETP inhibitors, which increase HDL and lowered LDL. And to save time, what we can do is look at basically a summary coming from a news report. But what we had is multiple trials. Tens of thousands of people were studied. Drug companies spent over $1 billion developing this category of drug over the course of about 20 years. And it really comes down to this, dashing hopes. The cholesterol drug had no effect. And so this is over 10,000 people were studied. No benefit whatsoever, heart disease or stroke. It says here the investigators were stunned. There was no benefit with a dramatic reduction in LDL levels. And so this part of it was Stephen Nichols, who's an expert in heart disease, statin advocate, said this drug seemed to do all the right things. It lowered LDL, raised HDL, and he said it's a mind-boggling question as to why it was so ineffective. Well, if LDL is not causing heart disease, then it's not a mind-boggling question. Lowering LDL provides no benefit because LDL alone does not cause heart disease. And it's really important to understand this is a kind of a drug that is relatively specific to raising HDL and not lowering LDL. We're going to contrast that now with statins. So statins now, the wonder drugs, the go-to drug, the drug that's now being prescribed to tens of millions of people because it is seen as almost a cure for heart disease. So here's a study published almost 2 decades ago in Lancet. Lipitor reduced heart disease by 36%, a powerful effect, and this is why statins are seen as the wonder drugs. Over a third of the people, therefore, would not have a heart attack as a result of being on Lipitor. And this is really what propelled Lipitor to generate hundreds of billions of dollars in revenue, because it has such a powerful reduction in the incidence of heart attacks. So let's look at this study. So to show you that 36% is accurate, here it is in the study published in Lancet about 2 decades ago. Reduction in fatal and non-fatal coronary heart disease. Well, what I did was I took the data from that study and I'm graphing it here in terms of the percent of people that did not have an adverse event. An adverse event, for example, would be dying. So we're looking at the percent of people that did not die, and that's in survival. And you can see here, like so many heart disease studies, these people were terribly uncooperative. Almost nobody died. Almost nobody had a heart attack. And so you can see survival. You can see no cardiovascular death, no stroke. And so somewhere in this graph is a 36% reduction in heart attacks. I kind of call it a Where's Waldo because it's really kind of hard to see. And it's right there. You see that? That sliver of a difference on the far left slide between the red and the blue. That's the people treated with Lipitor versus placebo. And you're looking at fatal and non-fatal coronary heart disease. That difference is a 36% reduction in the incidence of heart attacks. Now, when I show this to people, you know, I don't have an audience in front of me, but when I show people this, I get this look from this little guy. It's the same look I get from the public, I get from cardiologists. It's like, come on now. Seriously? I wasn't born yesterday. That's not a 36% difference. Yes, it is. That difference is a 36% reduction in the risk of a heart attack. So let's see how that can be a 36% reduction. Well, the actual difference is 1.1%. So 98.1% of the people on Lipitor did not have a heart attack or die of a heart attack. 97% on placebo. So doing nothing on the placebo, 97% of the people did not have a heart attack. The difference is 1.1%. So the ad, though, says it's 36%. So are they lying? How can it be 1.1% and how can it also be 36%? Is this fraud? Actually, no, this is not a lie. But let's look a little more closely at that advertisement. Amplifying. Did you notice the blue font on the blue background? In a clinical trial, 3% of the patients on the sugar pill, the placebo, had a heart attack compared to 2% taking the Lipitor. So they're telling you the real difference is 1%, but the ad is also saying it's 36%. How can they do that? Well, let's look at how you can do this. And I kind of call this statistical alchemy. Be able to turn lead and data into gold. Okay. You take the 1.1%, which is the real difference, called absolute risk, divided by 3%, which is the rate of heart attacks in the placebo group. 1.1 divided by 3 is 36. Yes, seriously, I'm saying 1.1 divided by 3, that's 36. That is called the relative risk reduction, and that allows you to legally say you have reduced the risk of heart disease by 36%. Now, why don't the statin makers, drug companies, give the real data, which is the absolute risk compared to placebo? Lipitor reduces the risk of heart attack by 1%. Well, when people look at that ad, obviously they're a whole lot less likely to want to buy the drug and how to use it. So 36% is a lot more impressive. But realize the real difference with this drug treatment is so incredibly trivial. Frankly, I find it outrageous. And in fact, I was so motivated and so outraged by this that I had the pleasure to work with Ufi Ravenskov. And about 6 years ago, we published a paper describing all the different trials in which this kind of statistical deception has been used to amplify the appearance of statins to be wonder drugs, when in fact, when you look at absolute risk, the differences are minuscule. And we talked about the war on cholesterol and how the effects of statins have been amplified and the adverse effects have been minimized. So let's look at a study people like to refer to, one in which provided the best effect of statins, and this also involves secondary prevention. So this is the 4S study, published almost 3 decades ago, and it's the best finding of all. And we're going to disregard that this was a study designed, implemented, and the data were analyzed by the drug company, something that couldn't be done now. But let's accept that, because this is a kind of important study. And even though they imply it's a 4% difference, it actually was a 3.3% reduction in total mortality. The advantage of this study is that it was reanalyzed in 2001. A subset of the data were reanalyzed. What's really important here is you have 2 groups of people. Both have high LDL, but they looked at outcomes in this study for people who had high triglycerides and low HDL, which is unhealthy, compared to the people that had low triglycerides and high HDL, which is healthy. What's really important is both groups had high LDL. So what was the outcome in terms of coronary events and the effects of statins in these 2 groups of people? The first important thing is it confirms that having high triglycerides and low HDL is unhealthy. You see a lower percentage of people over time with the open symbols, a lower percentage go without having a heart attack. Okay, and that's the open circles going down. So it is unhealthy having high triglycerides, low HDL. The statin-treated group that was unhealthy had a lower rate of heart attacks. This does show that there is a benefit of the statins in this group. My guess, my hypothesis, is because statins also reduce coagulation and reduce inflammation, and it has nothing to do with LDL. But let's look at the people who had the low triglycerides and high HDL. When you look over time, you see that, first of all, these people had a lower rate of coronary events compared to the people with high triglycerides. But the most important thing is there is no difference in the curves for the people that had the filled data points. They overlap. There is no benefit of the statins for this group. This is the closest we can come to looking at people who have the kind of biomarkers for someone on a low-carb diet and asking the question, would taking a statin benefit someone who has the low triglycerides, high HDL, and high LDL? And the answer is there's no obvious benefit whatsoever. And in their summary graph, you can see what they call the lipid triad. High LDL, high triglycerides, low HDL. These are unhealthy people. There was a statistically significant benefit. But for the people at isolated high LDL, meaning high LDL, but the other markers are good, there's no benefit of the statins. And again, this is the closest we can get to see that a statin would not benefit someone who's following a low-carb diet. So to summarize the statin benefits, there is a small subset of studies providing evidence of a small benefit in coronary events and outcome, and it ranges from about 0 to 3%. Okay, that's really the range of all the studies on statins, and most of them really were done over a decade ago. There has never been a study showing benefits for people who are relatively healthy, that is, for non-smokers, for people with low triglycerides and high HDL. So it's probably helping a subset of people who are unhealthy because they have excess coagulation, inflammation. It has nothing to do with the LDL reduction. So what about the adverse effects? Are that small benefit? I mean, still, if 2 or 3% of the people have less heart attacks, that's fantastic. But are there adverse effects? Well, yes, there certainly are. So in a brief period of time, I want to cover some of the adverse effects that have been documented. So we know, it is established, that people on statins develop more diabetes. And this is probably one of the best studies that was done. Here you have a prospective study. Nobody's got type 2 diabetes in the beginning. You got a placebo group and a group that gets statins. These individuals in this government-funded study monitored their fasting insulin, their fasting blood sugar. And so you have multiple measures of type 2 diabetes, and you find after about 6 years, in the placebo group, you've got spontaneous development in about 6% of the people develop type 2 diabetes. But those on the statins, almost twice as much, over 11% of the people develop type 2 diabetes. So this is quite dramatic. Think about it. 5% of the people are now developing diabetes compared to the placebo. And that increase in diabetes now increases someone's risk for multiple diseases, not only heart disease, but also cancer and brain diseases such as Alzheimer's disease. Now, it appears, and that study was done exclusively in men, women appear to be more sensitive to the diabetes-producing effect of the statins. So here's a paper published by a group that analyzed the incidence of diabetes in studies in relation to the percentage of women in the studies. With an increased percentage of women in the studies, you see overall an increase in diabetes developing in the studies. And at the extreme right, the Women's Health Initiative, which was all women, you see the highest percentage of people develop type 2 diabetes. And so the group concluded that there is a profound association of statin use to the development of type 2 diabetes, perhaps even far more susceptible. Women are more susceptible than the men. Now, the cognitive effects of statins have been downplayed. This is an incredibly important study that has been ignored, published almost a decade ago. And what you have here is people who are about 75 years of age had gone to the doctors reporting cognitive impairments. They're diagnosed with mild to intermediate dementia. And so what they did in this study was they took them off of their statins. And we know that they were off of the statins because their cholesterol levels rose. And after about a month or two of being off of the statin, their cognition improved to the point where they no longer are diagnosed with dementia. And what's critical is now you put them back on the statins under controlled conditions. When they were put back on the statins, their cognition worsened. And so the dementia diagnosis returned in these people when they were put back on statins. And we have published a paper as well on this topic showing that the initiation, the presence of the adverse effects, the cognitive adverse effects, is associated with the capacity of the statin to be able to access the brain. And so they can get through the blood-brain barrier and then interfere with the ability of the brain to produce its own cholesterol. The brain needs cholesterol to produce new brain cells or neurons, to produce new synapses, to make memories. And so the kind of statins that can get into the brain, such as Lipitor, are the ones that have the highest rate of adverse effects reported to the FDA. And so clearly now what we have to be concerned about is with this epidemic of Alzheimer's that we have. The question is, how many 75 and 80-year-olds taking statins are reporting now to have dementia, but it's a false dementia because it's caused by the statin, not by any genetic or other cause for someone to have Alzheimer's disease. We don't know because the studies have not been conducted. Now, I don't have time to go through all the different kinds of adverse effects, but they're published in peer-reviewed medical journals. And here's just a subset of the adverse effects of the statins. What you have is erectile dysfunction, low testosterone, kidney disease, muscle atrophy, and osteoporosis. All of this to get about a 1 to 2% improvement over doing nothing, taking a placebo. So, in summary, what I've talked about is that cholesterol has been the focus of research for decades. The linkage of LDL to coronary heart disease is incredibly weak. So why is cholesterol under the streetlight? Well, what I really focused on is to explain that something with such incredibly poor evidence to link one factor to another, to link LDL itself to heart disease, the primary motivating factor is profit. And so now you can see so many products, oatmeal, corn oil, Lipitor, as well as the newer drugs, the PCSK9 drugs. What's ideal, you want to sell Cheerios, you say it's heart healthy. What's ideal is to continue to demonize cholesterol and specifically LDL because it enables you to sell your product. But frankly, there is no strong scientific basis for the continued demonization of LDL cholesterol. So statins specifically have had meager benefits. We're really talking about single digits benefit compared to doing nothing. About 1 or 2% better than placebo in all of these trials. So the benefits have been inflated. You hear about 30, 40, even 50% reduction in events. This is called relative risk reduction, which is a way to inflate minuscule benefits. And the adverse effects have clearly been ignored. They have been dismissed. So what I've talked about are factors that really are far more important for improving cardiovascular and overall health. We want to get our triglycerides lower, raise HDL, and minimize the small, dense LDL. And the optimal way to approach this is with a low-carb diet, keeping blood sugar low, minimizing consumption of food that will raise blood sugar. FH has been seen as a disease of cholesterol. And what's clear is it is not, first of all, it's not a disease because the people with the highest cholesterol are actually incredibly healthy. And as they get older, actually having lower rate of death. Are statins of benefit for someone on a low-carb diet with high LDL? There is no evidence that you will benefit by taking a statin by lowering your LDL cholesterol if you're on a low-carb diet. And finally, what we really want to investigate and study even further is the coronary calcium. It appears as if this is associated with the high triglycerides, metabolic syndrome, high blood sugar. And in fact, taking a statin, there's strong evidence increases coronary calcium. And there's evidence then that having low blood sugar is associated with lower coronary calcium. This is something that's so incredibly important, but has largely been ignored in the literature, primarily because there is no drug that will lower coronary calcium. And I want to leave you with a review we published about a year ago. I had the great pleasure to work with numerous cardiologists, other clinician scientists, and experts in nutrition and diet, published basically about the benefits of the low-carb diet, and that there was no reason for someone with extremely high LDL levels to go on with the recommended diet, which is the low-fat, the low-saturated fat diet. There is no reason to restrict saturated fat for basically anyone, or specifically, especially someone with high cholesterol. And this is one of the figures from our paper. And it's so important because it shows relative to the general population, the people with FH, again, extremely high LDL, you can see if you have low fasting insulin and you're not overweight, the rate of heart attacks is no different from the general population. And it's only until you see those individuals that have either high fasting insulin or you have high fasting insulin and being overweight, you're about 7 times more likely to have a heart attack compared to the general population. And again, this is independent of the cholesterol, independent of the LDL. So ultimately, what really matters then is keeping that blood pressure, the blood sugar, triglycerides low, which automatically then results in higher HDL. The LDL turns out to be irrelevant. So I want to acknowledge that I've learned from so many people. Just as Isaac Newton centuries ago said he stood on the shoulders of giants to see further, I have seen further because of the scholarly work of so many people I've depended on. Here are a couple of books that I would recommend. I have a chapter in each of these books, and there are many other chapters written by scholars. So I highly recommend follow up this talk by looking at these 2 books, and I thank all those individuals who I've benefited from. So I'm on Twitter on almost a daily basis. My username is LDL Skeptic, and I look forward to interacting with people, and I certainly look forward to the Q&A session that will follow this. Thank you very much.
Thanks, David. Another talk full of information. It's hard to get your head around all the different things, but it just shows again how LDL has been demonized as the cause of everything, and it's amazing how that can happen when there's really so little evidence.
And especially, I mean, the evidence that LDL is a problem relates to this subset of LDL, the small, dense LDL that we find in this atherogenic dyslipidemia. And on the balance, people with higher LDL levels live longer. I mean, it's like with a lot of things in nutrition, the opposite is true.
It's scary stuff, really, isn't it? And obviously, there's a lot of money to be made out of people with high cholesterol because there happens to be a drug that can lower cholesterol occasionally. And we've heard in your talk and in this and other talks about statins. But obviously, a lot of the patients that we see who come to us for dietary advice with chronic disease, they might have diabetes, they might have metabolic syndrome, etc. Many of them are taking statins. And what do you say to those people? What advice do you give them about their statin use?
Well, first of all, I guess the way I see my role as a doctor is as somebody who educates the patients. I mean, to doctor means to educate. And it's not to impose upon a patient my will about what I think they should or should not do. So I present patients with the evidence. So if, for instance, there was a diabetic patient and they were taking a statin, and we saw that when they'd started taking the statin that their glycemic control had gotten worse, I would educate the patient about this. If, for instance, the patient had elevated liver enzymes, evidence of liver damage that got better when they stopped the statin, that's another education point. If we saw evidence of muscle damage, because we can measure for enzymes of the muscle cells dying, again, it's about educating the patient these are the potential side effects. And then it's also, I guess, balancing this against the potential benefits, which, as David has very clearly pointed out, there's a big difference between results if we present it as absolute risk reduction or relative risk reduction. And I present the data in terms of absolute risk. And at the end of the day, I then let the patients know it's not up to me to make the decision about what's right for them. It's my job to make sure they have access to the best scientific information, and then they can make the decision that's right for them. And of course, this is all very, very individualized. So we're not just going to look at an isolated LDL level on a blood test and make a determination. We want to know, is that LDL, atherogenic? Is it small dense? Do we need to run a blood test called a lipid electrophoresis? Do they have calcific plaque in the arteries around their heart that we can detect on a coronary artery calcium score that is a very good predictor for risk of heart disease? Do they have diabetes? Do they have poor blood sugar levels? All of these things feed into the bigger picture of evaluating somebody's risk. So I guess to make a long answer short, we manage everybody as a unique individual. There's no such thing as blanket recommendations. And number two, at the end of the day, the patients are the ones who make the decision. And it's my job to make sure that they've got access to the best possible information that they can possibly have.
Yeah, I agree completely. It's a big challenge, but it just frustrates me that there are so many people out there who are on statins and their GP, cardiologist, whoever, is absolutely convinced that it's of huge benefit. I remember talking to my mother who recently passed away at the age of 99, but I think she was 90 at the time, and she was having a lot of muscle pain, which I was quite sure was coming from her statin. And I suggested that maybe she should discuss with her cardiologist going off statins, and her cardiologist got very angry and said that there are thousands of people who'd be dead if it wasn't for statins, and you are certainly staying on your statins. So she continued for the next 9 years of her life to be miserable because she had muscle pain from her statins. But what can you do?
And the ridiculous thing is that in the insert in the box of the statins that she would have got, there would have been a warning that says they should only be prescribed with caution in people over the age of 65. And this is true of all statins. The side effects get worse, they're riskier the older you are.